G'day, welcome back sports medicine fans, and welcome to episode 91 of the Sports Medicine Project. I'm Blake, got a couple of lovely new listeners, and I'm here with my co-host Kelly Kortik. How you doing, Kelly?
I'm good. How do you know we've got new listeners?
Well, the listener count is up, and you can see it, so it slowly increases the longer the episode is out, which makes sense. But you can generally see if you have new listeners within the first 7 days, because it gives you a metric to see how many listens you get in the first 7 days, and then it slowly goes from there. And we got a bit of a bump, but obviously don't really have any other reason to think other than we had Professor David Hunter coming on talking about osteoarthritis. I've spoken to lots of people who will quote that podcast for me. Went for a run with Travis from Two Functional Souls. He's a Brisbane pod, messaged me down in Newcastle on a trip and said, "Oh, do you want to come out for a run?" We went for a run this morning and we were talking about that podcast and some of the things he was saying. And he was saying he was using some of it with his patients, which is awesome.
That is cool.
Yeah, so that's really cool. It's incredible to think how much reach it can have just by, someone incredibly smart donating their time. Then we package it up, put it out to people. Lots of people listen to it. Then that gets to their mind and that gets to their patient. That's a long journey.
Yeah, it's cool. We're at the center of that. And I think we spoke about this. Where were we? Oh, it was on the Stronger Stride podcast. We were talking about the why behind why we do this podcast and what we enjoy about it. And I think that's so part of it for me, is just being able to generate these conversations with these experts who can digest all of this information and all of the research so well and make it so translatable to you guys and have it as an easy resource for you to sort of gravitate to and really get some good things out of that's going to help you as a clinician and then your patients with their outcomes. I think that's great.
Yeah, definitely. I think that the learning part to me has always been number one. I mean, building this every week and putting in the time and the effort. I remember saying to myself, because, we certainly don't make any money off this part of the podcast. We do it because we want to learn and we want to become better. But I remember thinking when it was kind of like episode 20 to 25, I just spent a lot of time editing and reading and talking and finding guests and that kind of thing. But I remember thinking, if nobody listened to this podcast at all, it was just me and just you, I would still do it, because just the matter of doing it, I'm learning and then being able to have these awesome conversations with other people, not just with the guests, but people that are, ask me about osteoarthritis, or other clinicians or the students at the university or colleagues. So it's really cool.
Yeah. I had a thought, actually. I was... when Sophie was talking to us on the Stronger Stride podcast about the fact that we haven't had much debate and much argument lately. Because in my head, when she said that, I was like, I feel like we have had a lot, but I realised it's all been on the Patreon episodes where we really get into each other. That's where we start to unleash a little bit. I feel like on this side of the podcast, we probably have been a little bit more in agreement maybe and having just conversations and discussions. But when we get onto the Patreon, that's when the claws come out.
Yeah, that's true. Got to put it behind that wall.
Yeah.
But on that topic, our Patreon is growing, which is great. We've finally decided, which we wanted to see if anyone out there would come and listen to us chat clinical case studies, research reviews, and a little bit of the presentations that I've done online. But it is slowly growing, which is awesome. So we've decided that we're going to do kind of a week on, week off, where a full week we're just going to put all our effort into the Patreon, where we're going to do plenty more video content. All my webinars and presentations and things that we both do will be on there. We'll be looking at research reviews, talking about some analogies. We've finally got the office set up in our house, so we've got the whiteboard out and that kind of thing, which is going to be awesome. So that'll be a full week just focusing on that, and then a week after then focusing on the main podcast page. So nothing's really going to change. We're probably going to have longer episodes, but we're going to have them less frequent, which will be awesome. But now we're not talking Joe Rogan style. We're not talking 4.5 or 4 hours. We're probably talking maybe an hour, 90 minutes.
I like those longer ones though. You don't like them, hey?
No, I like them if it's an interesting guest. But I do enjoy them.
And the Rich Roll podcast, that's a long one too, but I kind of like them. If they're only 30 minutes, I look at them like, I'm going to skip to one that's like an hour and a half.
Yeah.
So I know that I'm going to be able to commit to that for a while.
Yeah, one of the difficulties for us is certainly organising times with people to discuss. It's usually during the week. When they're on the weekend, it's awesome because then we can talk over or we have spare time. But generally, we're doing this pretty consistently. We used to do we still do on a Thursday in our lunch break, where sometimes we're running late or we're running back to back with patients. So it's going to be a little bit more in depth, which is awesome because the longer you speak, the more questions you can ask, and the more kind of clinical just questions on the spot that come up.
Yeah, and we're in a little bit, I wouldn't say a dry patch, but we're just a little bit in limbo between asking guests at the moment. So if anyone has any recommendations for guests for us to reach out to, let us know. We're going to do a bit of a bulk message around to a few different guests that we've had on our list that we would love to interview
we've got guests
lined up.
Yeah.
Oh.
Yeah. We do have some guests lined up. I know because you don't go onto the calendar or anything like that. You don't see the schedule coming up. It's just we've had a couple of weeks between them.
Oh.
Yeah, we've got plenty coming up. So to sign up to the Patreon, if you think it's worth it, certainly if you don't think it's worth it, that's fine. We're still going to be doing the main show and plenty of content over on the Instagram. But it is a oat cappuccino extra hot a month, which is $6.50 depending on where you're going. And that's access to everything. And yeah, head over there if you think it's worth it. If not, if you want to just help keep the lights on at the show, that's awesome too. But we'll keep delivering this content because it's awesome and we enjoy it, and you guys obviously are too.
Mm-hmm.
So today we're talking about the continuum model of tendon pathology, which I'm sure you have all heard of based off that paper back in 2009. I'm sure you guys have seen plenty of studies and plenty of media content and gone to plenty of courses and talked about the tendon continuum model. But there was a paper that came out in 2016. It was called Revisiting the Continuum Model of Tendon Pathology. What is the merit in clinical practice and research? So we're going to talk about that today, which is really just talking about how do we think tendinopathy occurs. And this kind of come up because I'm doing a presentation for our Australian Podiatry Association. I was really trying to understand as much as I possibly could about what's the current thought around how we go from healthy tendon to pathological tendon. I'd heard of these models previously, but probably hadn't dedicated a full couple of days of trying to understand them to this degree. And obviously talking about them with you sparked a little bit of our conversation this morning. So I thought, why not talk about it here?
Yeah, I'm looking forward to this conversation. I'm interested to see where it goes because I feel like this could be one where the claws do come out a little bit.
Yeah, I don't know. I think we're in agreement. I think what I really struggle with, and I don't know if there's other people out there that feel this way, is what happens when, so let's say you've got a healthy tendon and you load that tendon, and the story goes, you load a soft tissue, you give it enough time to recover, and then adapts to that stimuli and becomes stronger as a result. But when you load that tendon, what is happening? Does it become stronger and more resilient because there's thicker fibers, or the collagen is thicker, there's more collagen? Does the extracellular matrix change and it's a good adaptive change? Or how do we know what is kind of happening? And I want to know what's happening, which I don't think we're ever going to, but this paper shines a little bit of light on that, kind of the theory behind it. What do you say? Because we were talking about it before when you were saying, like, yes, you become more resilient, but what do you mean by that, more resilient?
Well, my argument is, and this is just...
Not an argument, just a point. We haven't even started yet.
I guess just my point that I had was, from a clinician's perspective...
Yeah.
Why does that matter?
Yes, I know this question comes up all the time, and you're right. It doesn't matter for us to help people, but saying if we say that to everything, well, it's like what's the point of trying to understand anything?
I agree with you.
And it matters because we want to build on the current understanding of where we are. Because if we find something out, like as an example, what we now understand based off some studies that have come out around tendons and loading tendons, we used to think that heavy eccentrics were it. It has to be heavy, it has to be really challenging. And then if we just said, why does it matter? Let's just keep it heavy. People are getting better. And then we kind of understand that perhaps it doesn't have to be as heavy, and perhaps the tendons don't have to change in their structure for people to get better. Like, that's probably known from asking these kind of questions.
Yeah, and I agree when we're talking about why we're doing a particular intervention and why we think a particular intervention is going to be important or not.
Yeah.
When we start to break down the nitty gritty, I think there's a lot of question marks around pathology and why it becomes symptomatic and why things are painful and why they're not painful anymore for lots of injuries and lots of conditions in the body. And what this paper highlights, or what one of the first things I highlighted when I was reading this paper, is that tendon pathology is a risk factor for tendinopathy.
Yeah, and tendon pathology, you mean change to the structure,
yeah,
like a
essentially
tendon disrepair.
Yeah, it's a risk factor for tendinopathy. So it's something that you can observe on an image, similar to osteoarthritis. Knowing the like cellular changes and why that's going to, and how that's going to help a patient, I don't know that it is, if you think of it from that perspective.
Well, what if I mean, you are... Yes, you are definitely right. When we ask these kind of questions and when we discuss it on a podcast, how much is someone going to be able to take, what is happening in their cellular level into their clinical practice? Probably not much at all, if any, but I hope and think it's interesting to discuss and talk about, because perhaps if we understand it better, we can maybe be able to tailor our treatment a little bit better to individuals.
Yeah, and I also agree with that. I'm contradicting myself a bit. I think we spoke about this a few weeks ago or months ago, and I was talking about, it's so important that we know like the iceberg as well, like, the iceberg that sits underneath and then not just the tip is what we would explain and tell patients, but we need to have a good understanding of that, all that foundation underneath it, to be able to, explain that well and be able to help them understand their pain and their problem. So maybe this falls into that, and it's just a whole nother layer.
Yeah, well, like that, the tendon pain, structure and function, and that as it's progressing throughout the last several years, that's been a huge change in my clinical practice, where perhaps focusing on pain isn't the best for us initially. Perhaps it is. Perhaps focusing on function is better. Perhaps doing both at the same time, or knowing that the structure of the tendon is very unlikely to change, but people can still get better. And perhaps people with Achilles tendinopathy, if there is a subgroup that really do need to do some heavy eccentrics, or there might be another subgroup that doesn't really have to do any heavy loading, or they just have to do consistent loading.
So what were your main questions that you had when you were looking at this study? Like, what was the reason that you were gravitating towards this study, and the questions that you were looking for answers? Yeah,
so as we were saying today, when I come out from the office and put it up on the TV in the lounge room, like bone seemed to make so much sense to me, where, briefly touching on them, you load a bone, you have some damage, a microfracture occur, you have osteoblast.
I can't remember.
No, osteoclast come over, and these are the ones that take away. Osteoclast come over, they remove that bone at that area. There is an increased amount of porosity. The bone is a little bit more fragile. Osteoblasts come in, targeted remodeling internally and remodeling on the surface. That can take anywhere from 3 to 12 months. Full mineralization, the bone is then more tolerable to tensile and compressive forces. That's like the elevator pitch to some degree. But when we talk about tendons, I could not explain it the way that I just talked about the bone, where you you load a tendon, and then what happens? Is it damage to the extracellular matrix? The tenocytes respond. You have all these cellular changes, and then as a result, the tendon is damaged, and then it repairs and recovers and then becomes stronger. But what is repairing and covering? Is it the fibers that are becoming thicker, or are they becoming more tolerable? Like what is happening there?
Well,
or the cells, we're going to talk about like the tenocytes and things like that.
Prior to reading this paper, which it does talk about in here, it talks about 3 different types of responses to loading, or the pathology cascade is how they point out. But my understanding would be that the tenocytes are responding to load, and maybe they're responding to load in the way that's going to be most optimal for the load or the particular type of stimulus that has been applied to them. So if they're getting exposed to lots of speed or lots of springing, then it's the tenocytes that are going to be turning over or changing or adapting. Then if they're responding to spring or those faster energy storage and release types of loads in combination with compression, then maybe there's going to be more like calcium deposits that are going to be trying to come in and repair and remodel that tendon.
And what happens? So when you say remodel, what comes to mind?
I don't know. I don't care.
Yeah, I was just asking. That's all. If you don't know, that's fine.
I don't think I care about that, to be honest.
Yeah, which is fine. You don't have to. But I think if we're talking about it, and that's the question I want to know is what is changing. And again, if I'm explaining this to people, I'm not talking about it anyway. But just for my own personal view, I just wanted to know what remodels.
Yeah. Okay. I don't want to overcomplicate things though. I think there's a risk to diving too deep and just completely overcomplicating it so much that it's almost going to be less helpful for both you and your patients. If you're going down to that cellular level.
As I was saying before, I don't go down to the cellular level with patient in any way at all. I explain it very simply in layman's term. As I was saying, I just want it to be for myself. That's all.
Okay, so what have you found?
Well, I don't actually really know. I haven't found too much at all, but the categories that they talk about, which we're briefly going to touch on, like the continuum model. The continuum model is one of several models on the pathoetiology tendon pathology continuum. The three groups, depending on the primary or key event in the pathology cascade, can be 1, collagen disruption and tearing, inflammation, or tendon cell response. So the tendon cell response encompasses the tenocyte change, the tearing and collagen disruption is probably one of the first ones that started, but doesn't encompass the changes that we see on a cellular level. So they say, while collagen tearing may not be the primary event in tendon pathology, understimulation of the tendon cell may play a role in degenerative pathology. So looking more further, you're on that one. So looking more further into the inflammatory model, I thought that one was...
Wait, I wanted to talk about that. I just can't find it on here because I don't know how to work your computer. Oh, there. Yeah.
So this lack of tendon cell stimulus may explain the limited reversibility of degenerative tendon pathology and lack of remodeling following exercise-based interventions. So the basis of it, which was first by Alcredi et al., proposed that tendon pathology may be driven by understimulation of the tendon cell due to a lack of load transmission through the torn collagen fibers. Yeah.
There was a other bit that they wrote in there too, that it was talking about like laxity, like tendon laxity, like it loses its sort of stiffness or it becomes more lax, or what it says in here is that there's early changes more as fiber kinking or loosening of the collagen matrix. And so maybe that is those cases where they do lose that stiffness or that spring, and it's really hard for them to develop those skills in energy storage and release. And then the other thing that I was thinking about, like from that, with these different models, and they kind of allude to that in the discussion as well, is that it's unlikely that there's one thing. Like there's probably a combinations of things going on. And maybe, from this, like in terms of understanding that iceberg a little bit better, if we can do a good thorough assessment and maybe identify what that deficit is in that person. So maybe they do have good strength, but they don't have that spring. Like I guess maybe you could be thinking more along the lines of the collagen matrix that's loosening, and that's the thing that you're really going to be developing from a clinical standpoint, and maybe that's what's going to be most helpful for that person.
Yeah, I agree. And yet you're right with multiple... I think these are all theories, aren't they, at this point? But it's still interesting to hear and see. I mean, the inflammatory model is the one that, and recently they've had was that in 2018, they had the consensus statement to move away from itis and more to opathy or osis. But what do you think of the inflammatory model?
That's been my understanding from when I started as a clinician, that it's tendinopathy because it's not... there isn't any inflammatory markers, or the inflammatory markers are quite low, and not necessarily, they don't support the inflammatory the inflammation as being like the primary event or the key contributor to tendon pathology. So I guess there is a little bit of inflammation present, but not enough for it to be a real driver of nociception is my understanding.
Yeah.
And I highlighted that section at the bottom there, that the tendon cell is mechanoresponsive and it responds to overload and then stimulates that matrix remodeling. So maybe that's what you can sort of say when you're talking about like when you load it, what's happening is that matrix remodeling or that degeneration and synthesis rather than...
Yeah. So a tendon cell is mechanoresponsive, releasing cytokines in response to overload that then stimulate matrix remodeling, which they call degradation and synthesis. And as you touched on before, they do mention that there is a presence of like inflammatory substrates. However, it doesn't necessarily mean they are the primary event or the key driver of tendon pathology. And yet it's clear that when you see these changes in cyclical load, you see changes in these inflammatory markers.
Yeah.
But then because then you think of, like, say for example, thinking of that as a case, does that mean targeting, like let's say the inflammatory model was case in point, it's definitely clear that this is exactly what is happening, or that it is something inflammatory. Does that mean targeting it more with anti-inflammatories would be more effective?
Yeah, maybe. Or maybe they might be someone that does need a period of deloading, maybe. Yeah. And then the other one is the tendon cell response model. Now this is right up your alley. Yeah, I think I like this one the best. Maybe this is just where my bias is going towards, or maybe because we spoke to Ebony Rio and she just had such an eloquent way of explaining this that I just understood so well, and I think it is so in line with my bias that I just run with it all the time.
Yeah.
And I'll be happy to admit that we've all got biases, and I think that the way that she explains it is right up my alley, so I like going with that one.
Yeah, and we'll link this paper in the show notes, but I'm going to read this part here which explains tenocytes quite well. The tenocyte is primarily responsible for maintaining the extracellular matrix in response to its environment. Changes in tendon load and biomechanics will be sensed by the tendon cell and result in a cascade of responses, cell activation, extracellular matrix, collagen chain, that kind of thing. So a tendon cell-based response logically explains the tendon's adaptation to compressive loads that occur in the development of fibrocartilage within wraparound tendons, like the Achilles if you're running uphill, which is exactly what you explained. One thing that they did touch on is it's unclear how collagen disruption tearing models of tendon pathology account for these features. If you've got increased laxity or tearing disruption, how do you then adapt and have these things happen within the tendon, which this model accounts for?
So are they saying that they can't happen at the same time, or that if one of these theories is true, then the other isn't? Is that what that means?
Well, no, it was just saying that when you're looking at the other model, which was the collagen disruption tearing model, which is the oldest and the one that they say is the most open to challenge, it is unable to account for these adaptations to compressive loads that occur in the development of fibrocartilage or more tenocytes for more tensile load. Does that make sense to you?
I don't really get it, but that's okay.
There's lots in this paper that is true, because it kind of makes sense because it's worded very well, and then you get to a couple of them, you're like, okay, now I need to go back and read that again.
Yeah.
But they answer some cool questions, like the next one, what is the relationship between structure, pain, and function? Which this paper was out before the new paper had come out, saying that not really any studies have looked at whether or not when you get better and feel better and function better, whether you need a change in structure. So we can't really say that needs to happen or does happen.
As we were speaking about at the start, they sort of highlight at the start that tendon pathology is a risk factor for tendon symptoms. So I don't know that it has to have a relationship. But then remember we were talking about I think it was on that podcast that we didn't get saved, but that Keith Barr paper where he was talking about the fact that tendons can heal and you have to treat different portions of the tendon to help with that specific structure that's degenerative or reactive or whatever. I can't remember what that was about. Do you remember that conversation and what the specific exercises were? an isometric is going to treat this portion of the tendon,
Oh,
whereas
you
an
hold it
energy storage release is going to treat
part.
this portion.
What does this mean to you?
Just ignore me.
No, I do remember, but I can't actually remember the exact details, but I do remember that paper, and it was something to do with the tendon and the
alludes
holding.
to the pain, structure, and function conversation.
Yeah.
Because that in his philosophy, I guess we could say, he thinks that you can heal tendons, or you can treat specific portions of the tendon to encourage better structure and therefore healing and pain and symptoms.
And for people listening, what that means is, the research talking about, you have part of a tendon, which we're going to get to, a part of the tendon that comes degenerative, or they call it tendon disrepair, and that part of the tendon isn't able to transmit forces and mechanical load as well as the healthy tendon around it. And what Kelly was saying was, he was saying that you potentially may be able to actually treat that part of the tendon.
That would be cool to get him on the podcast. I feel like we
he would
refer
be
to
really
him
cool.
quite a bit.
That would be really
Let's
cool.
add him to the
Could imagine
list.
if you could do that. Imagine if you could, let's say you purposely develop a tendinopathy, so your tendon gets thicker, and you develop all this degenerative tendon disrepair, and then you switch it up and then actually trick that into becoming more of the tendon, so you inherently then have a thicker tendon where you can use all of it. How's that for a logical leap? What do you think of that? So you get your tendon thicker by making it degenerative, and then you actually
treat it,
and
so
turn
then
it back.
A functional
tendon, and then you've still got your healthy tendon around it.
Well, isn't that the same as rehab?
Yeah, but that part of I guess in some papers they do say that normal part of the tendon around it then becomes as strong, if not, or can get as strong, if not stronger, than what it would have with the degenerative part and the healthy part. That's right. Yeah.
So what's the difference?
Well, you would then have because without that, your tendon, I don't think, would be thicker. Because I don't think your tendon gets as thick. So if you have normal healthy tendon and you load it and never have any tendon, well, thicker would be the sense, because then you've got more tendon. I know where you're trying to go, and I've got you in the corner. It's actually the other way around. So if you have thick and degenerative tendon, your tendon's going to be thicker, right? I'm not saying thick is good or bad, but then because you're going to turn that back into healthy tendon, then you've got more tendon, more volume that you can turn back into healthy. So rather than having 100% of healthy tendon,
Do you want a thick tendon or a long tendon though? If it was me, I'd rather my tendon get longer.
I don't know, but I mean, I think if you had it thicker, you're going to be able to potentially store more energy and release more energy. I don't know the answer to that. I probably shouldn't say that, but I think that maybe it would have some potential benefit, because if you've got more of something that can store more energy, potentially that might actually make you be able to then use that energy. How do you think? You thought I was going to say? Because I agree that, it doesn't mean it's always going to be better, but if you could turn it back into healthy.
Just ignore all of that. That's just all discussion.
It's just a logical leap. All right, now what does this sentence mean to you?
Okay, go. Hit me.
Interestingly, progression and worsening of tendon pathology over time appears to be a greater risk factor for the development of pain than the absolute extent of pathology itself. Oh, okay, now I read it out loud. It makes sense, because I read that, it didn't make sense to me. To read it again.
So just pathology on its own isn't a risk factor, but if it's getting worse.
No, it is. So
I mean, but a worse risk factor is if it's progressing.
Yes, so progression and worsening of tendon pathology over time appears to be a greater risk factor for the development of pain than the absolute extent of the pathology. And when they refer to pathology, they mean of degenerative tendon.
So they've just taken an image of someone in 2021 compared to 2025.
I don't know what they've done. I haven't actually read the study. That was just in the. Because
the first person that's got the extensive pathology would have had a worsening of that pathology at some point.
Well, I think they mean
pathology.
Well, not necessarily, because you can have.
What just goes bang?
Well, you can have degenerative tendon without pain, and without loss of function.
They're talking about pathology. So they're saying a worsening pathology is more is a higher risk factor for pain than if it's bad. If it just looks bad. Yeah. But the one that just looks bad would have gone through a worsening of tendon pathology at one point, right?
Yeah, I guess so.
So then what's the difference?
Yeah, I don't know.
It's just different
I didn't
points
understand
in
it
time.
until I actually read it out loud and you explained it back to me, which is good. That's why I wanted to ask your opinion, because I couldn't really fathom it in my head, but now it makes sense.
But that's just a bit dumb.
Well, they said it was interesting, so I think it must be interesting.
Maybe we're dumb. Or maybe I'm dumb.
I'll take that bet instead of these incredibly smart researchers. Now, one last part to that, they said there are clear associations and disassociations between structure, pain, and function, and a number of reviews have focused on this complex relationship in tendons. Tendon pain is partly related to function, with tendinopathy decreasing muscle strength and motor control, which in turn reduces function. So you can say there is some relationship with structure and pain, which obviously makes
And then also
makes
why
sense.
strengthening and resistance training is beneficial.
Yeah. Now the next part, where does tendon pain fit into the continuum model? And I think this is probably the easiest to think about, where you imagine this is the donut theory, where you imagine a reactive tendon with the first presentation of tendon pain following acute overload, and a reactive on late disrepair degeneration tendon pathology. So an easy way to think of that, do you want to explain the ovals? You probably explain it more than me. I used to explain it a lot at the start, but now I don't do it as much as I
guess
used to.
I think a lot of people would have heard that one before. So the treating the donut, not the hole. So that's the idea that the outside portion of the tendon is full of this thick, healthy, normal tissue, and it's the inside portion of the tendon that's the degenerative portion. And that's the older theory, that you used to treat the tendon and try and continue to keep the tendon nice and strong and robust and resilient, and not worry too much about the degenerative portion. But then the newer model, I suppose, came out to say that actually that healthy portion can become reactive and then on degenerative. So then you can have these reactive on degenerative tendons that you need to try and manage as well. And then that's where we get into that other tangent about Keith Barr talking about treating different portions of the tendon through different types of rehab, because then you can target different
which sounds very, very difficult, because you think of,
I know,
your tendons and muscles and bones, they don't have a mind of their own, they just detect a stimulus, so it's very difficult. I mean, well, we will have to reach out to him and see if he can come on and talk about it, and perhaps it's only early work and that kind of thing.
Maybe, I feel like what we were talking about in that podcast was that maybe the normal portion of the tendon can actually provide some sort of energy storage and release component, whereas maybe the degenerative portion is too degenerative to be able to do that, so it's not effective in being able to, I don't know, don't ignore that, people, ignore that. That's me guessing.
Now, in this part, they do talk about, which I know you have read more than me, that there's the potential for the degenerative tendon not to be able to generate as much nociceptive drive. Because yes, we're talking about pain, structure and function, but we then inherently have to then talk about pain, which is incredibly complex, as we all know, and we're not able to identify what's the cause of that or why it's worse in some people very, very clearly. But the paper does talk about that. Did you have anything to say on that?
Yeah, I like that when they talk about the peripheral nerve sensitization. Can you scroll down a little bit? So I guess one of the drivers of nociception that they talk about is the peripheral nerve sensitivity that's around the tendon, and maybe the mechanoreceptors around the tendon being enough of a stimulus to set off those peripheral nerves, and then your body interpreting or processing that as nociception and then pain. And then that they talked about, like, when it's a pain-free tendon, that may contain enough substantial matrix and cell abnormalities, but limited nociceptive substance production, signaling ability, or receptor activation is an insufficient nociceptive stimulus. So again, really complex and not something that you'd necessarily be explaining to a patient, but I guess from Blake and I's perspective, I know something that we've asked people before is, what has to change for someone to go from pain to no pain, and I guess that's a theory in why that might happen.
Yeah, and how some people consider tendinopathy to be centrally driven and questioning the relevance of local changes in tendon structure, but it seems to be a combination of both, where if we know that exercise is good for pain. They talk about a cool study that Emilio has done where unilateral isometric exercises in patellar tendinopathy have no effect on the contralateral pain, potentially suggesting that the local factors or pathways are critical in pain production. And they also talk about if people sprain their ankle, that they can have some secondary hyperalgesia, but then injecting it with an anesthetic can help. There is certainly something locally happening, but also probably something more centrally driven as well.
Mm-hmm.
Now, question for you. Is a response to load part of an adaptive or pathological process? What do you think there? Adaptive. So normal tissue responds to load with both synthesis and degradation of the matrix. However, turnover rates depend and they vary on the protein. So that is the change that's happening. It is the synthesis and degradation of the matrix, and the similar one there would be bone.
Mm-hmm. That's like, I guess, if you want the elevator pitch, then that could be the thing that you sort of explain, or that's what the main point that you're highlighting, I guess, in tendons, we think, at this point in time, to the best of our knowledge.
So the last 3 paragraphs they talk about, which are probably have the most clinical translations, are interventions targeting pain, interventions addressing function and low capacity, and interventions targeting structure. Now, the pain one is interesting because we talk about quite a lot that, just focusing on pain itself solely in isolation probably isn't the best idea, because you want to restore tissue deficits, get people back to the function they want to be able to get to. But it's probably worth mentioning that pain is the reason that people come to see us generally, or what that pain is stopping them from doing. And it probably is important to have some kind of pain modulation therapy or something that you can give that is going to help them manage it a little bit better.
I think that's particularly relevant and tricky also in the person who, let's say like an Achilles tendinopathy or a glute tendinopathy in the middle-aged person who doesn't do any physical activity, that's had this sort of insidious onset of tendon pain, maybe because they've had a period of moving houses or something like that that's just exceeded their capacity, and they're purely coming in for a pain, like a result on pain, and they have no intentions of doing exercise, which I think we see not much of this. Like I tend not to see too many of these clients or these patients. I think that's the trickier one to manage though, for that reason, because I think it's easy to have the conversation with someone about getting them back to their function and what they want to be able to do, and it makes sense to them as to why they're doing calf raises to then be able to run, whereas trying to convince someone to do calf raises for them to be in less pain when it initially might bring on a little bit of discomfort is a really hard conversation to have with some people.
Yeah, and a lot of the treatments that we hear about all the time is potentially not appropriate at all for tendons. They certainly are in some cases appropriate, and they have been shown to have short to medium term effects, and whether or not it reduces the barrier for someone to then engage with the therapies that they need to improve their function. If someone has a really sore Achilles or a sore tendon, and you can or they can take some anti-inflammatories or potentially have an injection or potentially trial shockwave. They talk about surgical scraping in some cases, and that...
I hate that. I hate it.
Probably just the word scraping. But if that potentially allows them to, which we don't always know and can't say it will, but if that potentially allows them to be able to engage with the things that will improve their function, that might be something that is worthwhile considering and talking about. So interventions addressing function and load capacity.
Right up my bias once again. It's the stuff I like.
Yeah. So that's the interesting one. And when we say function and load capacity, and I've certainly moved away from this now, I used to say strength to people, like we need to get you strong. Now I more use the words like, functional or robust or resilient, or, preparing you for the things that you do throughout your whole life. So
Why have you changed?
Because I don't think that, when we say strength, I don't know if people just interpret it as like, oh, okay, you want to not turn me into a bodybuilder, but like, all right, you want to increase how much I can lift. And that's not the goal of what I'm trying to do. And potentially when you probably are better, your strength may not have actually changed that much. It may just be the fact of you doing it. And if I'm seeing someone that's middle-aged or younger, I might say, we're just trying to increase your capacity to tolerate more stress. Yeah. So I don't really say strength anymore. And people think of as an example, a middle-aged woman coming to see me me for some tib post pain or Achilles pain, me trying to say, hey, we're going to get you strong. And they've never had any experience in the gym. They just want to be able to go for a walk and play with their grandkids and go and get a coffee. They're like, I don't want to get strong. Like, no, we just want to make you more tolerable to things you do throughout your life. It's the same thing I'm going to give them, but it probably has a little bit more understanding for them and easier to take in, I think, potentially.
Yeah, I think that's good.
Now, the interesting one, which is, we've touched on this for the whole podcast, interventions targeting structure. Now, this is the elevator pitch. The pathological tendon appears to effectively compensate for areas of disorganization by increasing in cross-sectional dimension to maintain sufficient volume, which is just awesome. So if someone's had tendinopathy, they've got their ultrasound images, you can clearly tell them that where your tendon is now, there are parts of your tendon that are going to be able to compensate for this, but for us to be able to do that, we're going to have to work through these logical graded exposure steps.
Yeah, and it's also a nice way to de-threaten the thickness as well. When people get really concerned about their tendon being a lot thicker, it's like, well, that's just your body adapting because it's going to take over for the part of the degenerative portion, and that kind of fits well when you're drawing like that donut and hole, I think, on the whiteboard, because you can draw it a little bit thicker and you can say, look, this is all that healthy tissue that's compensating for this inside portion that's degenerative. It's not thick because it's about to go bang.
Yeah, and we're going to build that up. I do wonder, do you think that, let me ask you this, you have two people, everything's been controlled for, they're twins. One person has a reactive on degenerative tendinopathy, and let me start again. One person has a degenerative tendon within their healthy tendon, so they've got bilateral thicker Achilles tendons. They have a degenerative portion and they have a normal healthy portion. And then you've got someone else on the other side who
they're twin.
Yeah, that they're twin, who has no degenerative change or proportion, and they are equally strong or equally equated for how much they can do. And let's say you want to improve their function. Do you think that there would be any difference in who would improve quicker? Do you think the person with the degenerative tendon would improve quicker, or the person with the, I know you're saying you don't know, but what do you think? Like, if you just wanted to improve their function? And function is defined as like how much they can tolerate storage and release energy and how long they can maintain that for.
I have no idea.
Do you think
I don't even know how to answer that question. No,
I don't think I worded it.
Like, the only thing that I could maybe say is, like, if someone's got a degenerative tendon, then maybe that tendon has been responding to some sort of loading. It's almost more unusual for someone to have a completely normal tendon, I would say.
Yeah. Yeah, because, like you said, well, you could just flip that and say a normal tendon is a tendon with some degeneration, isn't it? I mean, that's what people have spoken about on the podcast, where your body adapting to load is thickening and changes. So you see changes in your joint as a response to load. You would see changes in your tendon as a response to load.
Yeah, that's kind of what, but I don't know the answer to that.
But I guess the degenerative part is like tendon disrepair, whereas in that kind of first phase, which is like the tendon remodeling, yes, you could. Oh, now here we go. Now it's come to me. We're talking about like the continuum of a bone stress injury. Could that potentially be the same with a tendon, where you have a normal healthy tendon, you load it, it goes into that tendon remodeling phase where it is closer to the threshold of then turning into tendon disrepair and kind of tendon degeneration. But if it recovers and you give it enough time to adapt, it then turns back into stronger, healthier tendon.
I think that you've just outlined
the paper.
the tendon continuum by Jill Cook.
They're all continuums. Damn, I thought I was going to come up with my own continuum then, but Jill beat me to it.
I've got a question for you. From reading and going into depth on this paper,
we were pretty disjointed, weren't we? All over the place, but it was good.
What have you like learnt that's going to change your clinical practice?
I think it'll probably. I think it'll not so much clinical practice, but just talking about it with people. I would probably say something along the lines, and I'm going to continue to work on this, where you have a tendon and you load it. There is a cellular response where lots of things change. You have tenocytes, you have cytokines, collagen changes, and as as a result, you have tendon adaptation or tendon changes as a result of that. And then that is a potential of going into like a degenerative tendon if it goes further down the continuum, but if it remodels and changes, you then have a healthy, stronger tendon, which is kind of what I believe. I just didn't really know, and I wanted to know what actually is happening. And that doesn't sound, when I'm explaining it doesn't sound very coherent, but I know very clearly that if you're confident in something, that does not mean that it's more accurate. But I seem to read, and it just makes sense when I'm reading research about bones really clearly, but when I'm reading about tendons, not so much. I'm very happily admit that.
I think we also know less about tendons than we do bones.
But yeah, I guess clinical practice, it would make me think about more the reactive on degenerative, which I probably change that more now anyway, where I may not actually load someone as much as what I would, potentially thinking that they are at an increased risk of having a flare up, and we don't want that to happen.
When it's reactive?
Yeah, but then how do I know if it's reactive?
Well, I guess you treat their symptoms, don't you?
Yeah.
Like without
that is true.
Without
you
wondering,
just treat symptoms anyway. Yeah, I mean, you tailor an exercise program to where somebody's at right now based off symptoms and capacity. I mean, if someone has a really sore tendon, you're not going to get them to go out and run 20 kilometers or jump and hop and that kind of thing. Which the symptoms one is hard. I mean, not really, because then you could say that, you know, if someone has any central sensitization, let's say that we know it's both local and systemic level, if someone has more of that central sensitization and hyperalgesia, does that then mean that, I mean, it's what they experience, so then you would still tailor it to them anyway. Not to say that like pain is a great metric of tissue health in these long-term tendon cases, but it doesn't matter if it is or not, because you're still going to, and when they come to see it, because you're still going to tailor to their clinical symptoms.
Yeah.
But maybe potentially you actually do get them to push into pain a little bit, but then it depends on the person. So you're always tailoring it to them anyway. Depends on the person, the context, where they want to get back to. That seems really clear to me now. When we used to see it in webinars, I feel like I wonder if we go back and listen to the first episode when I spoke about this. I'm doing that thing again when I just jump from idea to idea. But when we go back and listen to the first episodes, I was like anti-stretching and now thinking about, you know, tailoring it to the person. But I think of that with tendons now, when I see it in webinars when I was younger, I was like, oh yeah, you just tailor it to the person. That makes sense. But now I'm like, yeah, it really makes sense. You really do have to tailor it.
Which is why when you, like, yes, this stuff is useful to develop that iceberg. But then when you have that person in front of you, what you do is going to just depend on what their beliefs are, what their ideas are, what they want to be able to do, what they're feeling, how it's behaving on that particular day, like all of that, what they've got, what the environment they're in, what they've got access to, like all of that just dictates essentially what you're going to do. So you can try to do the best based off the information that you have, but sometimes you can only do what the person's going to let you do. Truthfully,
I don't always go into and try and read this much, because I purely just want to always get to make my outcomes better. Like, I genuinely find this stuff interesting as well.
I agree. I think this is, and I think this is a good paper. Like, it's a good one to read, and it's not super long. I recommend you guys to go and read it.
It's open access on British Journal of Sports Medicine too.
Yeah, it's a good one to sort of brush up on your tendon pathophysiology knowledge.
Yeah, and it's not something that leaves, I mean, every paper will leave you asking more questions, but it really does have some pretty clear digestible information. Like, you don't leave going, oh, now, like, there's one like the tendon neuroplasticity one by Ebony Leo. That paper is hell. I've tried to read that so many times, and I have read it multiple times, and I couldn't tell you anything really from that paper clearly in the way that it was presented. But it was a good one. Enjoy, guys, and have a lovely week with your patients. We'll talk to you soon.